So I think the real taste of a pie is in having it. So however much a product may be good, and the claim may be from the industry of real use and practical use in clinical conditions, it is only when a clinician uses it, experiences it, and finds it clinically actionable, only then such a product can live up to its name. And today, that is exactly the intent of this webinar. So I, on behalf of HaystackAnalytics, very warmly welcome all of you for this, again, exciting session of clinical insights in using a new technology, infexn NGS, for infectious disease diagnostics. It's a new paradigm that is being set into motion and is gaining grounds in India. And I'm truly honored to have with us Dr. Himaaldev GJ, who happens to be a critical care expert. High regards for any intensivist, because while all of us medical professionals do deal with sickness, with various clinical conditions, I think it is only an intensivist who is always on the edge of the sword, walking that tightrope, and is at a race against time scenario, is on that horizon of between life and death. So it is a tough job. We can only try and make it somewhat easier for them, and that is our efforts. The effort for HaystackAnalytics started in 2019. It's a short and exciting journey. We used to call ourselves startup. Now I would rather call ourselves a scale up, because we have gained some grounds, given the support from the government, from various private sectors, from the science and technology partners in India and abroad. So that places us now in a very comfortable position to make a part of that claim that we say leaders in genomics. But again, over to Sir to walk us through his insights of whether the claim is right. So over to you, sir.
Yeah. Thank you, Dr. Mahua, for the wonderful introduction. So what I'm going to do is probably start directly from the case scenarios. Then I'll explain and we'll talk more about the wonderful technology, what we have in our hand right now, which is really a boon for us. As she rightly said, the intensivist has to be on the edge of the seat, so he requires all the weapons. So the faster we get everything, the quicker we can act, and the faster the patient gets to go home. So that is what is happening nowadays. I think we are not resorting to the old methods of, even though it's a gold standard, but still, like for example, a blood culture which takes, and the sensitivity which takes around 72 hours or more sometimes in case of fungal infections. So you can't wait for that report to adjust your antibiotics, because the disease doesn't wait till then. So, over the years, it has been proved and proved again and again that the earliest initiation of antibiotics is going to change the outcome of the patient. So that is what we will be dealing. So we'll come back to these slides again, but I'll start with our cases so that we understand better how we can utilize this kind of technology. Okay, so coming to one of the cases which we had recently. So a young man who was 28-year-old, he admitted with fever, myalgia, rashes, and decreased urine output. And he was in another hospital, so he was initiated on cefiperazone sulbactam, and he was treated with IV fluids and supportive measures. And of course, dengue is quite prevalent at this time, so his dengue IgG was positive, and they thought to have dengue, and he was treated like a dengue. And what happened was he progressively became breathless. His shock was worsening. He went into acute kidney injury. Overall, his condition deteriorated, So he was shifted to Apollo Tertiary Care Hospital, but with septic shock. So when he came to us, so when we evaluated him further, this was his X-ray. So of course, it looked like what is called as a pneumonia, probably going into ARDS. And so he was intubated and ventilated. And our protocol is whenever somebody comes with a pneumonia, we usually go for a community-acquired pneumonia protocol. The only thing is we escalated the antibiotics to meropenem because he was in severe shock. and it was already third or fourth day of his illness, and he was from the other hospital where antibiotics already were in. He was in a BL-BLI combination. Then we put him on azithromycin for atypical cover, and doxycycline to cover the tropical fever workup panel. And because it all looked like fever, rashes, a bit of thrombocytopenia, and oseltamivir as a coverage for a viral pneumonia. So this is what our initial coverage was. So he was intubated. So we got a bronchoalveolar lavage done and a sample sent for NGS as well as a routine culture. And we sent a blood culture also. And over the days, he became, over the hours, he started to develop this kind of rash. So, of course, whenever we have this rash, we think of tropical fever or a vasculitis, or if it is a sepsis with DIC, or sometimes sepsis causing purpura fulminans. So this was the situation. And so what happened was we got a skin biopsy was done. This was during the course of the illness. But before that, we got this report. So when we sent for NGS, within 24 hours, we got this report, which proved out to be a mycoplasma pneumonia. So blood culture, of course, was no growth later on, and there was no tropical fever organism there. So from meropenem, doxycycline, all oseltamivir, all the antibiotics, we just continued with azithromycin. And of course, whenever there is a severe pneumonia, there is a role for steroids. So we put him on steroids for hypoxic event, and he was in shock also. So there is a stress dose steroids. But this helped him a lot. Patient gradually liberated from the ventilator, and he was discharged home with completely recovered organ functions. And he came back to visit us with all normalized rashes, nothing, no other organ dysfunction at all. So what highlights in this part is another one which we missed is which I missed telling you is for the skin rashes, we got a skin biopsy done, and this turned out to be a leukocytoclastic vasculitis, which is classical of erythema multiforme, which happens in atypical pneumonia. So what was missed is an atypical pneumonia coverage. So we went through the studies. The slower you start them on the atypical cover workup, that's how this progress. Generally, the atypical pneumonia doesn't go so bad. Probably the coverage was later, and that's why he took a long time and he went into multi-organ failure. And usually these atypical organisms are called atypical because they are not usually easily identifiable or by culturable. And their presentation is not like a typical pneumonia. They don't have a lobar consolidation. You can look, this is how it looks like in an X-ray. It has got a diffuse patches everywhere. And they have extra pulmonary manifestation like joint pain, myalgia. They can have renal failure, and they can have these rashes. So these are all the guide. And again, the tropical fever was a confusion. So just by doing one single testing, which is NGS, or this is what genomic sequencing, which I'm going to tell you later. It's a simple blood test. When you do it, we got the report within 24 hours, and that changed everything. The antibiotic de-escalation, right antibiotic, and no need to panic over this multi-organ failure. We know there is a diagnosis in hand, the patient will get better. So this is how rapidity of diagnostics helps us to get the patient better. Atypical presentation, a lot of confounding factors, but one good test and the rapidity of the testing help to save this young man's life. So that's about case one, where mycoplasma pneumonia was identified by NGS. Blood culture didn't show anything in that. This is case two. So this was a 38-year-old lady who has on a veno-venous ECMO. Whenever the patient is on a severe ARDS, we put them on a machine called as an ECMO, where you take over the function of the heart and the lung, and the ECMO serves as a oxygenation and carbon dioxide removal device. So she was already on day 14th of ECMO. And in spite of ECMO, on 15th day, she started to have lung function worsening. She was recovering, but later she started to have because she became hypoxic, and she became more septic, and septic shock happened. And the lungs were worsening. So we did a bronchoalveolar lavage. And in hospital, she was already on antibiotics, but in hospital, she developed this. So this was a secondary infection, probably. We thought it could be a hospital-acquired pneumonia or a ventilator-associated pneumonia. And somebody, based on our antibiogram, our Klebsiella, Enterobacteriaceae are quite common, especially the NDM organisms or OXA48 groups. So that's why we escalated the antibiotic to ceftazidime-avibactam and Astronam. That was a common decision which we do it when the patient deteriorates on ECMO. And we did a BAL and we sent for NGS and also we sent for culture. And this was the report which happened within 16 to 18 hours. And the report was Acinetobacter baumannii. You know, the Acinetobacter baumannii doesn't respond to ceftazidime-avibactam Astronam. If I didn't have this report, probably I would have continued the patient on ceftazidime-avibactam Astronam for another 3 days till I got the blood culture report or ET culture report. So this was another case where a 45-year-old presented to us with fever and pain abdomen, and patient was in shock. And of course, when the patient comes with fever and shock, we always think it is a septic shock. Then we start the protocol. We give them, we draw the blood cultures and we start the antibiotics as early as possible. Because in a septic shock, we have to administer the antibiotic within 1 hour of presentation. Because every hour delay is going to be a troublesome for the patient. We got an ultrasound abdomen to see why the fever was there and what's the source of sepsis. But ultrasound didn't reveal anything. No pyelonephritis, no biliary sepsis. We started him on a good antibiotic, broad spectrum. We sent the blood for next generation sequencing and blood cultures as well. And when we evaluated further, this was the picture. This was not an infective pathology at all. It was an inflammatory pathology. It was pancreatitis. So this patient didn't require antibiotics at all. And when the NGS came to us within 16 to 18 hours, so this was the report there. There was no organism detected. So it actually reinforces to de-escalate the antibiotics, reserve that antibiotics, because pancreatitis do not require antibiotics. You can use it for later purposes when they really get infected. This helps in de-escalation purpose. So that's how this NGS can help us to de-escalate these antibiotics early so that we don't irrationally use the antibiotics. So these are the other cases. A patient comes to us with an UTI and a septic shock, and based on the antibiotic, when the patient is in shock, we generally start them on a higher antibiotics like ceftazidime-avibactam in hospital. And when the NGS report comes, it comes as a CTXM or ESBL E. coli, which doesn't require a ceftazidime-avibactam. We can easily de-escalate to a lower antibiotics like carbapenems. That's how another de-escalation process happens if we have this report early. These pancreatitis are all SIRS response. You don't require antibiotics that. And antibiotic is not a sign of, fever is not a sign of an antibiotic deficiency. So don't jump on putting an antibiotic to somebody. Use the clinical picture and the diagnostics in a judicious way so that you don't jump and deal with the antibiotics. This is what we generally use to detect sepsis and septic shock, an infection with the SOFA score system, which can guide us whether to give an antibiotic within first hour or not. These are other confounding factors. So this is a Plasmodium falciparum, which can present to you like a septic shock. You don't require an antibiotic there. You have to use an antimalarial there. And of course, this is what, again, which can present to you like a septic shock, dengue. Here also, you don't require antibiotics. So detect all these things. There are certain panels in NGS which can guide you better so that you don't waste your antibiotics or just get confused with other infections. So you have a thing in hand. Not only those, some other infections like in case of CSF sampling like meningitis, where it is very difficult to grow these organisms. These NGS can help us to detect the organisms, especially when you know the organisms, there is a possibility of drug-resistant Streptococcus pneumoniae, where you have to use vancomycin, and many of the setup, they don't use it, and ultimately the prognosis is bad. So here, it can guide you to use what is the right antibiotics and early therapy. And of course, when you want to decide on certain this was also a case from our hospital where patient was supposed to undergo a pacemaker, but unfortunately he had a candida growth, candida from NGS detection. So this was an early detection. If he had waited for the blood to grow and what species and all those things, it could have inadvertently led to his getting a pacemaker and later pacemaker to getting infection, because it's a very expensive device, and once it gets implanted, it's difficult to remove it. So these things can guide us whether to judicially use these antifungals to start them empirically, wait on the pacemaker insertion, and once the blood is cleared of this, we can start put the pacemakers later. And again, the fungal detection by this is very good compared to our traditional techniques where it can go missed or it takes a longer time to identify these organisms. 1 hour bundle is very important, especially when the patient comes to us with septic shock. We don't have much time. We jump on antibiotic. We have to give them antibiotic. And these are the different ways of resistance mechanism. And our next generation sequencing test not only detects the organisms early, it gives us antimicrobial resistant genes. So which is the right now, hot cake where you decide your antibiotic therapy just by looking at these genes. So we have different kinds of resistant genes, and how this is how the different mechanism of resistance happens to antibiotics. To make it simple, this is what the enzymatic degradation happens, and this is what detection happens in case of NGS. Other than these, there are other ways the organisms can develop resistance. They can do a target site modification. They can develop an efflux pump or a pouring channel where it can get lost, or they can form biofilm. This cannot be detected by your next generation sequencing technique, but this can definitely be identified, and you can get the antibiotic treatment right. This is how we divide these resistance genes: class A, class B, class D, and class D. All these things are identified within 24 hours of your blood sampling, so that based on whatever genes or resistant genes, you can tailor your antibiotics, either escalate or de-escalate. And this is a summary of all the different resistant genes and also the non-enzymatic resistant mechanisms, which happens in a case of, especially in a case of carbapenem resistant Enterobacteriaceae. And this is the commonest one which we see, that is CTXM, AMC, KPC, and OXA48, and NDM, commonly in our practice. All these things are identified within 24 hours of our blood sampling. And suppose if I identify a CTXM, then I know our BLBLI doesn't work there, so I have to go for a carbapenem. Again, AMC the same way. Sometimes FFIM can be useful there, but you have to go for a higher antibiotics there. If it is an OXA48 or a KPC, your ceftazidime-avibactam helps. If it is an NDM, then plain ceftazidime-avibactam doesn't help. You have to go for ceftazidime-avibactam and astrodome combination. This is how I tailor my therapy when I get these results. Again, I told you there are different mechanisms of resistance. That's why only these resistance may not guide you. Sometimes there can be an efflux pump or a non-expression of gene. So you have to judicially use these reports so that we don't cause harm to the patient. And of course, there is a cost factor, but there is a way to curtail this cost factor. So usually if you use antibiotics for a longer duration, it is going to cost more than using these tests and cutting down on the antibiotics, so that you save on a cost, the length of the stay in the ICU, and also the patient getting out of the ICU faster. The cost will be much lesser to the patient. And why should you use these things? Because one is for contact isolation. If you have an XDR or an organism, you require a good barrier precautions for these patients, so that a next patient who is high risk should not get this infection. And for early initiation and also appropriate therapy, you initiate the antibiotic in the right way and also modify appropriately over the course of the therapy. And this is what the studies have shown, that every hour counts. Survival rate decreases by 7.6% if there is an every hour delay in the right antibiotic or delay in detective of specific pathogen. So these antibiotics are really, really, important. Very few of the antibiotics are left, and we have to use them judiciously. And this is where our next generation sequencing techniques helps us to get these antibiotics the right way. So the global problem right now is this. There is a lot of antimicrobial resistance happening, and if you look at it, the major cause of death is infections around the world. 49 million deaths, infection happening annually, and almost 5 million deaths are because of the drug resistance itself. And all the deaths, 30% of deaths happen in intensive care units. And this is what IDSA has come up with a lot of policies. Bad bugs, but there are no drugs available. So needs drugs later on, and there's a lot of public policy happening there. And there's a lot of cost involved trying to tackle these multiple resistant MDR organisms. And the most worrisome things are the escape organisms, which includes your Enterococcus faecium, Staphylococcus aureus, Klebsiella, Acinetobacter, Pseudomonas, and Enterobacter species. These are, the ones which are causing trouble to us because they are the ones which are more virulent, and they are the ones who are having high drug resistance. So they end up causing a lot of problems to our patients. They lead to mortality. They lead to increased length of stay in the ICU, increased cost burden to the health sector. So that's what you need to identify these organisms early, and they're not easily identifiable, and you can easily miss. And they take some time. If you go for a standard blood culture. And see, this is what happens if you want to identify an organism. You need to use multiple kits because there are multiple clinical conditions, multiple tests are involved, and the culture-based test, you can only detect what can be grown there. And if you go for a molecular-based test, you can only detect what is in the scope of the test. And again, you have to combine everything in interpretation is not that easy. And if you go for the commercial available panels, they have specific organisms, doesn't target everything. So you need to use multiple kits. The cost also keeps on increasing. And so we are changing the paradigm from hypothesis intense to hypothesis free, lesser hypothesis, more on targeted therapy. And if you look at the infection spectrum, if it is a community acquired infection, if the patient is in the ward or the patient is in the ICU, the test doesn't change much. The cost doesn't change much. The turnaround time doesn't change much. And the comprehensivity also is not everything is included. You have a specific organism. So if the patient is in ICU, in my ICU, he's very sick, he doesn't have much time. So he needs a specific test, which I can use it for a targeted therapy. It should be a faster TAT, and the cost should be suboptimal because he has other costs to tackle. The ICU cost is humongous. The ventilator costs are so much. The dialysis cost is so much. You add to that, it goes to cause problems. I need to reduce the cost by at least not abusing the antibiotics or overusing the antibiotics. So those things are very important, and this is what is going to be achieved if we use a targeted therapy or targeted diagnostic modality. The need of the hour is test should be a comprehensive, includes most of the organisms which is responsible for that kind of infection. Turnaround time should be faster. It should be sensitive. It should be specific. It should be precise. It should be cost effective, accurate, reproducible, easy to perform. And I told you golden hour, there is 1 hour in septic shock. It is very important for clinical decision making. So that's the solution with your NGS. So we have various generation of NGS, and I'm going to tell you how the NGS is performed, and it is gaining ground in infectious diseases. There are a lot of publications, a lot of reports saying that it can give you a faster diagnosis, and also very reliable, very sensitive, very specific, and it's got a high throughput, and it is the next generation sequencing has now becoming the instrument of precision public health, especially in case of infectious disease, and also to identify the antimicrobial resistance. So precision medicine is what we are trying to target, from intuitive medicine to empirical medicine. So, you're going to increase your use of antibiotics if you start everything empirically. So precision medicine can help you to curtail that, So that's what we need to aim at it. So this is what happens when I send a sample to next generation sequencing. So you send a sample, and this sample are directly processed, and the turnaround time is around 24 hours. It has pan-fungal, pan-bacterial, it has respiratory viruses and neuropathic viruses also. Not only that, it also gives you antimicrobial resistant genes. And this is all the thing which is involved here. This is the sequencer which is used. Dr. Mahua will tell you in detail later on after the talk, which uses Oxford nanopore technology, and the sequencing happens there and gives you a reliable report across the library of organisms which they have. And you can see there are compatible versions also, which makes things easier for them to detect. And this is how the sampling to be done for any clinician. When you're sending a sample, so these are the variety of samples which you can send. Of course, we always send a blood sample. Not only blood, you can also send a CSF sample, a nasopharyngeal swab or a oropharyngeal swab. If you have a liver abscess which is being drained by using a percutaneous technique, or you're doing an ERCP and you're taking the sample out, put it in the container and send it across. If you have a urinary tract infection, so the important thing is, suspicion of infection or localization of infection is very, very important. And if you're suspecting a urinary tract infection, then you can do a suprapubic tap, or a Foley's catheter is there. You can take out the catheter urine, but do not send a midstream urine sample because there's a lot of contamination. If you have a contamination, you will definitely get an organism there, and you will treat it by, it doesn't require a treatment. You will inadvertently treat it. If you have a bone infection, take a synovial fluid at a bone biopsy and send it across. And of course, pus from any sites. If there is an organ aspirate or a tissue biopsy, you can send the sample, pericardial aspirate as well. And of course, when you do a bronchoalveolar lavage and an endotracheal tube aspirate or a tracheal tube aspirate or a pleural fluid drainage sample and a lung biopsy sample can be sent for NGS. But do not send a sample of sputum because again, it's going to have a lot of contaminant there. So do not send a sputum sample, do not send a midstream urine sample, and there's no point in sending a stool because there's a lot of contamination there. Yeah, these are things which you should not send, and these are things which you should send. Suppose there's a degescenting happening for a pyelonephritis, you get a pus there, send it across, and you get the sample, the organism within 24 hours. This is what happens in the lab. There's a sample collection. As soon as the sample is collected, the DNA is extracted, and there is a pre-sequencing preparation which happens, and then there will be a sequencing through Oxford nanopore technology, and then finally there will be an analysis of the data across the library of organisms, and finally the report is generated. Generally, it may take around 12 hours to 14 hours, but only thing is because of it runs at a specific time. Generally, the TAT is around 24 hours. So 24 hours is a very crucial time. That is more than enough for me to get a hold of what antibiotics to be given. And since there is a continuous reporting process, so we get the report immediately, and there is a communication process which happens, and even if it is in the night, we change the antibiotics based on the microorganisms or the antimicrobial resistant genes. And the other good thing about this is whenever we send a sample, you need to actually give them the clinical details, because this is what is going to determine whether this patient's organism is it a contaminant or is it really an organism which is specific to that set of infection. So you have all the details here. What sample are being sent? What is my provisional diagnosis? What is the source of infection? Are you suspecting any contaminant possibility, and where is the sample is being collected? What antibiotic therapy or antifungal therapy the patient is on, because that also is very, very important. And finally, how is the clinical status of the patient? So this is for the clinician and this is for the lab. And generally we do fill it and send it across, so the decision becomes easier for the person who is processing the sample. And how this helps is, so generally if you go by a traditional method, you cannot detect you can actually misidentify the organism by various machines. There can be a requirement for the organisms to grow or identify in a particular technique. It can be a gaseous requirement, specific nutritional requirement. Some things are not culturable. Some organisms, especially Rickettsia, Leptospira, atypical organism, like in our case, the first case, where Mycoplasma pneumonia was one of the things. So these atypical organisms cannot be grown. All these organisms and some of the organisms which require tissue culture or animal model, all these things are not easily done if you use a traditional method. This can be done. This can be detected easily with our NGS. And this is an important thing which I discussed already, the fungal pathogens. Here also, if you wait for a traditional way, it requires all these temperature requirements, separate incubators. Incubation period is longer, so you require longer days, at least 7 to 14 days sometimes. So requires special media and the challenge of identification, the cost involved. NGS will detect the organism, the fungal organism within 24 hours. And we can also identify what kind of organism, so that we can change our antifungals based on the different pathological organism here. So that's about infection. So you suspect the infection, it covers almost all the organisms, including a syndromic approach here. You have neuroinfection, ortho, GI, bloodstream, skin and soft tissue, genitourinary, respiratory, ocular. Not only that, if you suspect a tropical fever infection, so there is a fever panel which comes across, which can give you all the tropical fever pathology, including dengue, malaria, leptospira, rickettsia, and your chikungunya, even salmonella species, typhoid and paratyphoid. So all those things can help you guide your, antibiotics or no antibiotics. Even malaria, falciparum can be detected, so you can start them on antimalarials. So this is how an NGS technique helps us. This one I already told you what are the samples to be given and what are samples should not be given. And this is how you send your samples. If it is a blood, you send it in a sterile EDTA vacuotinus, collect it in this, and do not try to get a hemolyzed sample or a clotted sample because it doesn't work very well. And always collect in a very aseptic technique, and do not use the midstream urine or a sputum sample. Okay, yeah. So highlights of this NGS is it's a culture-free test. The tag time is faster, reliable, and you should use your aseptically collected sample so that contaminants are avoided. So these are the organisms, especially escape organs. This is how the report summary happens there. So in Synotrophomonas maltophilia, it can be detected early. So your antibiotic choice is different there. Escape organisms are detected faster. You get resistant genes there. So even if the organism confuses you based on the resistant genes, you can tailor your antibiotics. Yeah. So these are a couple of publications in favor of NGS, where CRE has been detected very early, within 24 hours, with reliable. When you actually, the correlation with the blood culture later on also was always correlating very well. So you get an NGS report with an antimicrobial resistance. When you get a culture report, it is correlating very well, including the sensitivity of the antibiotic pattern. Again, the Oxford nanopore technology method of sequencing helps you to detect bacteria, fungi, and aerogenic, and is validated and it's been already published in these journals. So that's about the NGS technology, so which we are slowly getting adapted to, and which is quite reliable and has helped us to treat these patients, all these clinical cases which I discussed, especially in the high-risk cases, helped us not only to improve their outcome, but also to de-escalate the antibiotics, and also helped us to, get a hold of antimicrobial stewardship in a better way, not to irrationally use the antibiotics in these situations like pancreatitis, and de-escalation of therapy whenever we get a good, sensitive organisms. And so not to use detection of these organisms early when we use a tropical fever, the workup panels, and clinical decision becomes very easy, and save these antibiotics, use the right technique, and probably if you use it in a judicious way, you can overall improve the, the cost burden to the patient and also the morbidity and mortality of the patients.